Okay, so for the last section of this lecture, I'd like to talk just a little bit about the paradox of healthcare usage. And so what do I mean by this paradox? So what we're talking about here is the fact that there's both excess and deprivation within the healthcare system. And so we've talked already about a lack of access and equity, and that some people may not be getting enough care. I think that's very intuitive. It makes a lot of sense. Certainly there are people who don't have access to either for where they're living and the geographic region, or because of their economic resources and lack thereof, may not have access to care. And so they have a deprivation in terms of the amount of health care that they're getting relative to what they need. But we also see that there's a lot of excess of healthcare usage. And this is a little bit less intuitive, right? How could you have too much healthcare, right? What would that even mean? So I want to get into looking at what we're talking about here. And so it is true, and so we look at studies, and they do studies asking physicians, do you think that there's anybody in your practice, any of your patients are getting too much care? Is there anybody who's being overtreated? And 42% of physicians in the U.S. agree with that statement. Pretty high percentage in Canada too. I had trouble finding exact stats, but it seems to be also a very high percentage believe that there's an overtreatment of at least some of their patients. And so what's going on here, right? Of course, they're the ones doing this treatment. Why would they be doing that if they think it's too much? And this is driven by a number of things. One is that we have this assumption that more is better. We need to get as many tests as possible. We're also seeing a push towards having more of what we call wellness visits, right? Where you go to the doctor when you're not even sick at all, right? You go to have a wellness checkup. And so what we find in this, though, is that the more you examine a person, the more likely you are to find something wrong with them, right? If I look closely enough at a person, you will eventually find something that's not functioning properly. And so what we're seeing is happening is that as people get more of these wellness checks, or people, particularly high-income people who have access to a lot of healthcare, may seek additional testing that they don't really need for disorders that they may not even have. And so there is this excess of healthcare among some people. Right, and so again, going back to this idea of the more you examine a person, the more likely you are to find something that's wrong with them. And some of these things will be things that we definitely want to catch. This is a type of cancer that could grow quickly and cause a tumor in the brain and lead to death. But there's also a lot of things that could be wrong with us that if we didn't look hard, we would never know. It's not going to be the thing that kills us. There's lots of types of cancers that are very slow growing, and that many people, particularly later in life, may have, but won't be the thing that kills them. And so when we do more of this testing, and our testing gets better and better at detecting any amount of a pathogen or a tumor, then we're likely to again catch things that may not lead to a person's suffering or death, but the medical care that we give them to try to solve this issue could. And so this is what we're talking about when we're talking about an excess of healthcare in this paradox, right? The paradox is that some people are getting too much and some people are not getting enough. Right, and so what's interesting is part of how this was discovered. A lot of this data, again, comes from the U.S., but looking at, there was some interesting findings where it was like they were finding that the most affluent, or the richest Americans in California, they seem to be at a particularly high risk for getting certain types of cancers. And this was very counterintuitive. Usually cancer is associated with low income. And then when they dug deeper into these statistics, it turns out that it's because these high income people were going and getting tested a lot for these things. And so they were more likely to be diagnosed with certain types of cancers, but they weren't any more likely to die of them. In fact, they were less likely to die of them than people who were not getting those same diagnoses, people who were less affluent, right? And so what they were finding here was that many very affluent, very rich people were getting diagnosed with things that they wouldn't have ever known about, and were not going to be a cause of death, right? They were getting treatment for something that they didn't really need treatment for. Again, right, you're getting lots of wellness checks, lots of testing, extra MRIs, and so you may find something there that wouldn't ever cause a noticeable problem to you. Right? So what they call this is they're saying that they're getting overdiagnosed with cancer, right? It's not a false diagnosis. There is indeed some cancerous cells there, right? But some types of cancer grow really slowly and may never affect you, and some would grow quickly. And so overdiagnosis is when you're diagnosing people with those types that are never likely to affect them, and then engaging in all kinds of treatments to try to eradicate those, and the treatments can be much more invasive than the problem ever would have been itself. This is also driven a lot by just the economic model around healthcare, and this is certainly more exacerbated in the U.S. than in Canada, where we do have national healthcare. But the fact that you get paid more as a physician for the amount of care that you give, whether or not that care is effective, right? More tests equals more money, particularly for certain types of specialists, and so there's a whole economy around this that leads to excessive testing. Right, so this is the idea of getting too much care. We could also refer to this as overutilization. People are just overutilizing the healthcare system, particularly, again, affluent people who have the money and the time to do that, maybe going in for more care than they need. And in particular, a lot of so this is an older study now, but a good amount of healthcare services have no detectable beneficial effect, right? We may be hoping that they do. They may be an attempt to try to cure something, but a lot of things never actually benefit the person. And so we want to be careful about whether we're, accessing healthcare that's going to help us or is going to have no effect, or may, make our time more painful, or, have a negative effect, be invasive and lead to potential infection or some other issue. And so this is, again, seems counterintuitive. How could more care ever be wrong? But what we're really, again, seeing here is that sometimes, what's wrong with us is not as bad as the solution that we would use to solve that. That would be less likely to cause long-term major problems than some of the care that we might engage in, right? And this is particularly true with cancers where the chemotherapy is really invasive, really hard to recover from, really painful, right? And of course we want to do that if it's likely to be able to save you from a cancer that's going to kill you. But what we're seeing, again, is that people are being diagnosed with cancers that never would really have any kind of impact on their life, and being treated for that, and that does have an impact on their life. We also are concerned about this, right? Because if we're overutilizing healthcare, and there are, a good amount of complications that can occur. Things can go wrong when you're getting procedures done. There's, even with something relatively simple like an MRI, like things can go wrong there. I used to work in one of those facilities, and there's lots of stuff that can go wrong. You could get injured doing stuff like that. It's relatively low risk, but we, don't want unnecessary exposure to medical procedures because these can lead to complications. Again, this stat comes from the U.S., but that complications from medical care is the third leading cause of death. Right? So, again, there's risks associated with this. It's not just, more is always better in terms of medical care. And of course, there's also a cost associated to getting extra medical care. That means that money in a national healthcare system is not available for other people. In a non-nationalized healthcare system like the U.S., it means that they're still taking up doctors' times and facilities from people who wouldn't otherwise get that care. And so, again, this additional testing, right, we're getting better at testing, and we're also testing more, and our tests are becoming more sensitive, right? We're getting higher resolution in MRIs. We can, see smaller amounts of cells in the bloodstream or antibodies. Our testing is just getting more effective. But again, this means that we're likely to detect more things. And so as diagnostic technology improves, previously undiagnosed problems will be identified in many people who may not benefit at all from treatment. And this is what we're talking about when we're talking about a disease reservoir, is that, we all have things that could be wrong with our bodies. And if we dig deep enough and look hard enough, we will find these diseases. There's a whole reservoir of things that, we may know about but not have detected previously, because of our less sensitive technology, or we are discovering new diseases and new things that can be wrong with people. But again, in many cases, we may not benefit from that treatment. So what's the benefit of detecting that then? And so people in these cases may not benefit from treatment because the length and the quality of their life will never be affected by this thing that we found. And I think a really powerful illustration you can see in this study that I'm going to talk about here. So they looked at, you can people die of all kinds of reasons all the time, and their bodies get stored, and we do autopsies on those and can look at what's the cause of death in those cases, right? And so we can also look at, when we do those autopsies, what else is going on in the body? Are there other things that were wrong but were not the cause of death, right? We can look at the presence of cancers in the body. We can also look at, sometimes we know the person did die of cancer. And what they find here is we're looking at breast cancer and prostate cancer. And so among, the number of deaths that occur, 3% of people die of breast cancer or die of prostate cancer. But when you autopsy bodies, right, so people who've died for all kinds of reasons, 39% of them show evidence of breast cancer, and 46% of people, men particularly, show evidence of prostate cancer. Right? So what this is saying is that not that many men are dying of prostate cancer, but when men die, a lot of them have evidence of prostate cancer that was never affecting them and wasn't going to be the cause of death. And so again, this is speaking to that disease reservoir, where if we dig hard enough and we find these types of cancers, and then we do a lot of invasive stuff to treat them, that can really take away the quality of life and even take away years from people's lives when that cancer that they have was not going to kill them. And this is particularly true for breast and prostate cancers. There are types of breast cancers that grow really quickly and are really aggressive, and we definitely want to catch those. So don't avoid mammograms for that. But there are types that people can have for years, and the cancer never grows and never impacts them in any way. And prostate cancer, this is very true for. If most men, if they live long enough, will develop prostate cancer, but most of them are so slow growing that it will never have an impact on that person and won't be the cause of death. Right? And again, you wouldn't want to be, if that's the case, why would you want to be going through a lot of chemotherapy in your 60s? That could really damage your immune system and lead you to die of something else when that prostate cancer never would have killed you. So that's, again, is the disease reservoir, is that will more likely to find these things as we dig deeper and with better technology. And so sometimes when we have these types of breast cancers or prostate cancers or other diseases that aren't that we wouldn't notice or wouldn't even affect us if we didn't engage in these diagnostic technologies, we often call this pseudo-disease. Right? Certainly, pseudo-disease is a disease that will not affect the duration or the quality of life. Right? There's still cellular evidence of this pathogen. Right? There's tumor cells in the person's body, but those are never going to affect the duration or the quality of life. We would call that a pseudo-disease. Right? And so most adults rate their health status as excellent or good, but virtually all of us have some kind of problem that could be detected with modern technology. Right? If we dig hard enough, we could find something. And so this advances in diagnostic technology, while they can really reduce harm by helping us catch things that are aggressive sooner and treat those, they can also produce harm as they identify things that are pseudo-disease rather than real disease, and give people expensive, invasive, and painful treatments for those things that were never likely to be a problem. And so there's a lot of push based on this research for changing the guidelines for how often people should get certain kinds of diagnostic testing, and more interest in increasing our ability to distinguish between the types of cancers that are likely to grow quickly and be aggressive and cause a problem for people, and the ones that are likely to remain a pseudo-disease. So this is important areas for health psychologists and health messaging in terms of getting the word out there about, how often you should get diagnostic testing. And we're often pushing, you should get this, you should get testing as much as possible. And often that's actually not the case, right? We want enough testing to catch the aggressive things, but not so much testing that we're catching everything that's not going to cause a problem. So that's it for all of the new material for this lecture and for this course. So thank you very much. And I will maybe see you at the review session. So take care, and thank you for a wonderful course.